Well, thanks very much for the kind invitation and the very warm introduction, Edwina. So my name is Chilcot and I'm an academic psychologist working at King's College London. And I'm going to talk to you today about symptom perception from a biopsychosocial perspective. So that is really the integration between biological, social and psychological factors. So just to start, I actually have no disclosures to mention. So what is a symptom? I think this is a really intriguing question, and I had a good look at the literature on this, and there's no one agreed definition. I think it's the first thing to say. So this is one actually I've just pinched from the dictionary. So it's defined as a physical or mental feature which is regarded as indicating a condition of disease, particularly such a feature that is apparent to the patient. And I would add to that, it's also a concern to the patient in the context of an unpleasant symptom. But the first thing to recognise with this definition is it culturally appropriate? Would this construct hold true across the world, in fact? So there must be cultural differences in how people conceptualise and understand the sensation of a symptom. But an unpleasant symptom is a symptom that is self-reported and is perceived as causing suffering or some kind of distress. So that could be physical, social or psychological. So in the general population, symptoms are really common. So the median number of symptoms people report in the last week is around 5 symptoms. And people use Google an awful lot these days to search for their symptoms. Any guesses at when Google is most accessed to assess symptoms? It's nighttime, absolutely. So 64% of nighttime searches occur between 3 and 6 a.m. in the morning. And this is a massive study, albeit just in the UK, of over 40,000 Google searches. And people typically search for typical symptoms such as gut pain, depression, fatigue, nausea, headache. So this is quite an interesting study. But in terms of measurement, how do you actually measure symptoms? Because it typically requires retrospective recall. So as soon as we ask people to think back into the last week or the last 2 weeks, you tend to find that leads to a slight over-reporting of symptoms, and there's obvious response bias depending on how we frame the question and how we present the problems of symptoms. And there are over 40 different scales that have been used across the general populations and in specific populations of people living with a long-term physical health problem. So there's a vast amount of scales which obviously differ in quality and validity. But there are also newer methods of assessing symptoms, which include end-of-the-day diaries, or what we call daily reconstruction methods, and something which I think is really important is looking at real-time ecological monitory assessment, where you might assess on a smartwatch or a smartphone at several points throughout the day little rating scales of symptoms, but also symptom-related impairment. That's really what you're trying to capture. So you can look at the variability of symptoms across the day within people and also between people. So I think this is quite an interesting technique. And I don't think many studies in people living with kidney disease have actually employed this method. So why is symptom perception an important thing to consider? So it feeds naturally into the illness experience and contributes to health-related quality of life and symptom burden. It can guide what individuals do to manage symptoms, so how people access support, their help-seeking behaviours, the information they might try to gain about their condition and symptom. It can be implicated in treatment non-adherence, so quite often people use symptoms as a cue to whether a particular tablet is working or a particular regimen is doing them benefit or harm. And it can therefore influence future advice and medical decision-making. But ultimately, it's a key aspect, as I say, of the illness experience, but it's also such a fundamental feature of the placebo and nocebo effects, which we see in the majority of randomised controlled trials, and also in the real world. Remember, anytime we do anything, whether it's prescribe a behaviour, a tablet, a particular treatment, some of the benefit and some of the harm is attributed by the nature we've done something. So we call that the placebo and nocebo effect, which is very relevant to symptom perception. So when we think about symptom science, we can kind of break it up into 2 main areas. The first and really critical area is the pathophysiology of CKD symptoms, including some of the things that we've already mentioned, including uremic toxins, inflammation, protein energy wasting, the brain-gut microbiome, and even more recently I've discovered there's a brain-renal axis, for example. But when we think about symptom perception, we can carve it up in my mind into two sides of symptom perception. There's the first side, which is the initiation of noticing and detecting a symptom, which involves quite complex biological, psychological, and social interactions. So how is it that some people perceive a symptom? Then there's the other side of the coin, which is how do people respond to symptoms? So when they actually have a sensation, how do they interpret the symptom? So what's their cognitive appraisal? How does it affect their effects? So is it distressing, is it of concern? And how does it influence their behaviour? So I'm going to focus more on this side of the coin today, more around how do people understand and interpret symptoms and why is that important? So we've already talked a lot about symptom clustering. I think this is a really interesting area. So we know that the number and burden of symptoms in people living with kidney disease is comparable to those with terminal malignancy. So symptoms are very common and debilitating. And this is a fairly recent study looking at symptom clusters across different stages of kidney disease or modality. And overall, there is some consistency in how symptoms kind of cluster together, which I think is quite important. But one of the working definitions of a symptom cluster is it has to contain at least 3 symptoms. And the only other thing to say here is the statistical methods that one employs to do this type of clustering does vary. Some are good, some are less good. But I do think it might allow us to identify commonality from maybe a pathophysiological perspective or maybe a transdiagnostic perspective as to why do some symptoms cluster together, and if there are a combination of symptom profiles that really affect people's quality of life. So I think that's something to certainly look into. If you haven't read this paper, I would certainly recommend you to do so. It's a really nice paper talking about patient or person-centered approaches for the management of unpleasant symptoms. And the paper very nicely describes 3 theoretical models that for the sake of time I won't go into, 2 of which do feature this idea of the components of psychosocial factors that may contribute to the illness experience and illness management. So for the next half of the talk, I'm going to concentrate more on these. But as I say, this is certainly a very good paper to read with regards to the patient-centered approach to symptom management. So you can't really talk about symptom perception without talking about this overarching model that we use in health psychology that looks at illness perceptions. So this model basically suggests that following an illness experience or receiving a diagnosis, people hold mental models of what that condition is, and they also have an emotional response to that. So typically, when we think about illness perception, this has been demonstrated across many kind of illness conditions. So people hold an illness identity. So that's the illness label they have received or they think they have, and the symptoms they attribute to that label. There's also perceptions around the perceived consequence of the problem, how long it will last, will it be acute, cyclical or chronic, can it be controlled, can it be cured, what caused the problem, and an overall sense of coherence. Does the treatment match what they think their condition is, and does it help them manage the day-to-day symptoms? So people's cognitive and emotional responses to either receiving a diagnosis or first experiencing a symptom guides what people do to seek help. So do you first go to see a doctor about the symptom, and so on. And there's been a whole range of data looking at this model, and it's quite predictive of health-related outcomes, of which there's been a fair bit now in people living with kidney disease. So this is a study that's looked at from Holland, actually, looking at illness perceptions in people with progressive CKD. And here we measured a variety of illness perceptions using a validated questionnaire. And what it shows is people that hold views that of lower personal control, i.e. what I do doesn't really help control my problem. Those who have quite negative beliefs around their problems, and those with a lack of coherence, so they don't quite understand how the treatments they're being offered matches their condition, they might have a different view. Those factors actually predict declining kidney function, and it ranges between about 0.5% to about 0.7% per 6 months. Decline in EGFR, so that's quite a reasonable effect, even after you control for some important covariates. But the honest perception model is an overarching model that really looks at specific beliefs about kidney disease and that kind of thing. So the field has moved on to actually looking at more specific factors that look at how people think and respond to symptoms. So there's a questionnaire called the Cognitive and Behavioural Responses to Symptoms questionnaire. And this, we've just looked at this in some of our work, and we've shown it's quite valid. So there's different concepts here. Fear avoidance is the first main response to symptoms. So, for example, we might ask, am I afraid that I'll make my symptoms worse if I exercise? The second is damage beliefs. So this is a set of beliefs that a symptom is a sign of damage. So the severity of my symptoms must mean there is something going wrong in my body. The third, which is a very important one, is embarrassment avoidance. I'm embarrassed about my symptoms. I worry that people think badly of me because of my symptoms. Then there's a question around symptom focusing, so how internally focused people are and how sensitive they are at detecting symptoms. Then there's the behavioural elements, which is all or nothing behaviours. So that refers to when you're feeling, particularly in the context of fatigue, when you're feeling fatigued, do you do nothing? Do you really, not do too much in response to the symptom? But when you feel a little bit better, you then go all out. So it's this boom or bust type behaviour, rather than having some more graded approaches to your physical activity. And the final is resting behaviour. So staying in bed when you experience a symptom, again, is kind of related to this all or nothing type pattern of behaviour. So I'm going to try and bring that to life now in an example of fatigue, which we've already spoken about. And it's a very complex and multi-dimensional problem, is fatigue. And it can be defined as extreme and persistent tiredness, weakness or exhaustion, physical or both. And I would add to that, quite often it's not related to physical exertion. So this can be a common state when you actually haven't done any physical exertion at all. So we know it's got a very complex etiology, and it's likely to involve a combination of biological, psychological and social factors. But critically, there is no consistent treatment model of fatigue in people living with kidney disease, yet we know from the previous presenter the severity of the problem and the burden it is to people living with kidney disease. So this is an old review now, but it does show that the variability and prevalence of fatigue is quite varied depending on how one assesses fatigue. So there are quite a few fatigue measures out there, and that might explain some of the variability. But you also see some variability between modalities. But nevertheless, at least 50% of patients experience clinically meaningful fatigue, I would say, and that's probably actually an underestimate. So this is data that's modelled the severity of fatigue on your left versus fatigue-related impairment on the right. So it's very important, I think, when we think about symptoms, we don't just focus on the severity of the symptom, we actually focus, and one could argue maybe that's even more important, on the disability that the symptom actually confers. So this is modelled fatigue on the left versus fatigue severity against time on dialysis. This is for a sample of in-hospital chemo patients. So what you can see over the first 24 months, fatigue severity goes down, but then it increases over time. But you see the opposite trajectory with fatigue-related impairment. Fatigue-related impairment actually worsens in the first 24 months and continues still to rise, albeit at a slower rate. So there's two differentiating patterns here, trajectories of fatigue severity versus fatigue-related impairment. Again, this is relatively small sample size, but we know people who are clinically fatigued, so this is using a validated self-report questionnaire, have worse outcomes. So there's definitely an association between high levels of fatigue and early mortality in people on hemodialysis, and the same is true for fatigue-related impairment. So fatigue-related impairment independently predicts mortality even after you control for the severity of the fatigue. So it's obviously a very important outcome to focus on. So what might a biopsychosocial model of fatigue look like? So we can take the pathophysiology of fatigue as the primary driver of the symptom of fatigue, but the cognitive and behavioural responses to the symptom might explain how the symptom is perpetuated and maintained over time. So we might take the example of someone with uremic symptoms, with inflammation, all those kind of biological drivers of fatigue. Then there'll be a process responding to it. What does the symptom mean? Is it a sign of damage? then that might affect how people, or their effective response to the symptom. So it could induce worry, distress, depression, which might affect the kind of behaviours people do, i.e. I'm going to avoid activity because fatigue is a sign of damage. So you end up people being quite passive and not active, which can then lead to dysregulation of some biological processes, including things like deconditioning, worsening sleep quality, which can then reinforce the cognitive process. So this is a kind of classic CBT type formulation of the symptom experience, and it critically points to targets of where we might be able to intervene beyond just the biological management. So this is all big cross-sectional data to show that some of those cognitive and behavioural factors are important in explaining the variability of fatigue, so the differences between people. So this is a study where we looked at, again, hemodialysis. In our first model, we had some demographic and clinical factors, and that explained about 20% of the variability of self-reported fatigue severity. But when you add in some of the cognitive and behavioural factors, you can increase an additional 36% of the variability in fatigue can be explained, including distress. So there's a very strong relationship between a high level of distress and fatigue, but also this all or nothing type behaviour. So this boom or bust behaviour. When you're feeling good, you might overdo it. When you're feeling more poorly, you avoid any activity at all. And you see a similar kind of association when you look at fatigue-related disability. So again, a fairly modest amount can be explained by some of the background demographic and clinical factors, but you can increase the variance by an additional 44% when you look at how people think and respond to the symptom is associated with the level of disability. So that's cross-sectional, so I guess causality is certainly an issue. So we developed, actually, Plenary, who's now a postdoc working at King's, developed this intervention at the final phase of a PhD. So this is a cognitive behavioural therapy intervention called BRIEF to help support patients manage their fatigue symptoms. So it was a feasibility trial, so we weren't powered to look for statistically significant differences. So 12 patients were randomised to the cognitive behavioural therapy arm, which was a guided self-help book. So this is basically a manual that was developed with a series of activities that had some therapist support. So the therapist would contact the patient at certain phases of the CBT, just to see if they've got any questions, reinforce some techniques, versus a waiting list control who after the trial received the intervention. So we approached over 300 patients, and we managed to end up recruiting 24 who were randomised, 12 per arm. The consent rate was quite low, which is not that uncommon in doing this kind of work. So it's about 16%. So it's necessary to approach 13 patients to recruit one into the trial. But the rate of retention was pretty impressive. So 75% did remain in the trial. So although we couldn't do any significance testing, we couldn't help but look at some of the effect sizes. And there was a reasonable indication, albeit the confidence limits were quite wide, that the treatment was beneficial. It seemed to have a reasonable effect size for reducing fatigue, fatigue-related disability, and also depression. But it was quite a time-demanding intervention, so we need to think better about the feasibility of redesigning this approach to make it more acceptable to patients. But I think this is quite an important quote from, we did some qualitative interviews at the end to gain people's experiences. And this is from a patient who said, I was expecting to give me some remedy to a fatigue problem. That wasn't really the intention of the whole thing. It was to give you the techniques to use and analyse for the problems that you get. So I think that really encapsulates really one of the purposes of cognitive behavioural therapy. So just for the last bit of the talk, I'd like to just concentrate and reflect on some of the cultural and social demographic considerations when we think about symptoms and symptom perception. So the first and most important thing to consider is health inequalities in CKD. And I think symptom perception management may have a role in explaining some of these health inequalities. There are also likely global issues, including access to support for symptom management and treatment across all health professional areas, particularly the lack of psychosocial care in many of our renal units in the UK and most likely around the world. Then we've got the issues of access to digital platforms to monitor symptoms, remote telecare, for example, and other kinds of technological intervention, including the delivery of interventions using digital therapeutics. With regards to social and demographic differences, the literature is very mixed on this. The only consistent finding is that women tend to support more symptoms. But when you look at differences between countries and cultures, the evidence is very, very mixed as to symptom burden and the impact of the symptoms. And there are lots of issues here, and partly is because measuring symptoms and symptom-related impairment, we've got to consider, are they culturally acceptable? Are our measures culturally acceptable? And are they relevant to the population we're trying to understand? And how much tailoring needs to be done to make sure the constructs are well formulated, that we understand what symptoms mean in the particular groups we're looking at. Then obviously we've got the issue of health literacy, and the whole complex issue of translational issues. So for example, some colleagues in the UK, Shivani Sharma, has looked at depressive symptom tools in people with South Asian backgrounds, and they've done lots of work around translating common and validated questionnaires into different languages, including Urdu and Hindi. And the results are quite compelling in that there was some evidence that some of these could be translated, but culturally there are simply words that do not exist to explain the phenomena of depression. Think of all the words we can use to describe negative affect, depression, distress. These words may not exist in other languages. And that relates to the other point. Is translating a tool actually the right thing to do when the underlying construct of what is depression might differ culturally? So a lot of our tools are developed from the Western philosophy, the DSM or the ICD-10 of a clinical diagnosis of anxiety and depression. I'm not convinced that we really understand whether those models actually do sit and translate well into other cultures and other societies. So to summarise and give some brief conclusion, symptom burden is very high across the spectrum of advanced kidney disease. When thinking about symptoms, we must always consider severity and symptom-related impairment, and I would argue the latter is probably more important to the individuals. The pathophysiology of CKD symptoms, particularly things like fatigue, is not fully understood, and that really remains a critical research goal. But for many symptoms, a biopsychosocial approach is likely to be applicable, albeit we need certainly more research to understand these complex processes. But a patient or person-centered approach, I think, opens up the potential for more therapeutic and management options. And as we understand more, we need to test these interventions, not just their efficacy and how acceptable they are, but how do we implement them into routine clinical practice, given the context of which we're trying to deliver them, particularly the social context. And to end, really understanding more about how cultural and societal factors contribute to the symptom experience, the potential for treatment and management remains, I would say, a clinical priority for both research and practice. So thanks very much for your time. I look forward to any questions.